Got it? Okay. Well, thank you everybody for coming to our Talking Public Health series. I'm going to lean back on this last time I knocked off the piece here, but it's not here. So I'm very pleased today to introduce Beth Stelson. She's a postdoctoral research fellow at Harvard. And Beth has her MSW and MPH from the University of Pennsylvania and her PhD in social and behavioral science from Harvard. Her research focuses on working conditions and socio-contextual factors affecting the health of middle and lower income helping professionals. She does a lot of community engaged work. And she has an R36 from the National Institute on Drug Abuse that's looking at the measurement of exposure to occupational vicarious trauma to inform organizational interventions to protect workers. We told her that this is very unusual weather for us. We never have weather like this. Just as Sandro said, never. So we're
I also feel like totally responsible for bringing it with me. Sorry, everybody.
As we were getting blown away today. So I was worried you would get blown away, but you made it. So, but we're very pleased to have you here today, and we're looking forward to your talk.
Yeah, thank you. Can everybody hear me okay? Wonderful. So I'm delighted to be here to share some of my work, focusing on a topic I spent a lot of time thinking about, which is occupational vicarious trauma, and discuss some of the ways I think we can be moving this research and also practice forward to protect our helping professionals. So I want to start off with an overview of just like what vicarious trauma is and what we know about its impact to our healthcare and social service workforces. It's a relatively new topic of research, so I also then want to take a moment to talk about some noticeable gaps in the literature that I think need to be filled, and then transition to talk about two studies I led that's focusing on starting to fill some of these gaps, specifically to identify the physical health effects of vicarious trauma, and then to develop a tool to measure the exposure that Deborah mentioned. I then want to take a step back and think about, okay, what do we need to do next? What should we be concentrating on? And take the opportunity to lay out a research and practice agenda. So broadly speaking, my work focuses on how do we protect and promote the health and well-being of healthcare and social service providers, especially those working with the most vulnerable in our communities who have often experienced substantial and cumulative trauma. So briefly, why is it important to focus on these workforces? Well, healthcare and social service workforces are some of the largest workforces in our country, employing about 21 million individuals, which is about 14% of our US workforce. So it's an important occupational population unto itself. But from my perspective, we can develop all the best medical and social interventions in the world. But if we don't have a workforce in place to consistently deliver and a caring and compassionate way deliver these interventions, they don't make a whole lot of difference. And if anything, this can even serve to exacerbate health disparities based upon who can actually access the services. So what I'm trying to do with my research is really try to situate workers as an essential component of the care continuum. And right now, we're staring in the face of some pretty sizable workforce shortages that are going to have immediate impacts on adequate, accessible, and equitable care across the country. So these are screenshots, actually, from HRSA's 2037 workforce projections. And the orange represents the demand for workers, blue represents the supply. And as you can see, they're going in opposite directions, right? The demand for workers is far exceeding our supply. And with the behavioral health workforce, which is where I do a lot of my work, they're anticipating a workforce shortage of about 55% in the next 12 years, which is terrifying, right? So this shortage is due in part to demographic shifts in our population as we get older, increased prevalence of substance use and mental health disorders in our population, so greater demand, but also very real hazards that are affecting the workforce that's either disincentivizing people to going into the workforce or driving them to leave. So one such occupational hazard is occupational vicarious trauma, which is the trauma that workers experience indirectly when they're working with people and communities who've experienced trauma directly. So the workers themselves don't experience the trauma firsthand, though they might have some in their own personal lives. Because they're exposed indirectly, they also can be infected through the activation of psychological and physiological stress response pathways. And this can either be from a specific event, such as somebody disclosing a history of childhood sexual trauma, or it can be accumulated over time in the work environment. So you're probably wondering, okay, she's speaking about trauma. Why the heck does she have a picture of cigarette butts up here? And the reason is for two reasons. One is I think smoking can serve as a helpful analogy to scaffold our thinking around vicarious trauma. So when you have somebody who's smoking, right, they light up the cigarette, they're inhaling the toxins, but there's people around them that are also affected, right? Maybe they're in the same room, or the toxins carry on their clothes, they go to a next room, and so you have second and third hand smoke. And the same is kind of true. It's kind of a same analogy here with trauma. The second reason I have this up here is that I think we're kind of, if we're thinking about the trajectory of the research, there's kind of parallelisms with smoking and trauma. So when we first started to look at the health effects of smoking, we were focusing on that index individual. And then eventually we cottoned on that the effects are wider reaching. The same is true with trauma. We've made huge strides in defining what it is, recognizing the mental and the physical health effects. And then starting really in the 90s, we start to see the emergence of this term vicarious trauma, or some kind of compassion fatigue, emerge amongst mostly practitioners. And then it isn't until the 2000s that we start to have measures beginning to develop to capture the symptoms to vicarious trauma. And there's a body of research that emerges around these tools. And so we're kind of, the state of the research is kind of, we're in this transition period from kind of the equivalent of firsthand smoking to secondhand smoking research, the equivalent here with trauma, kind of in the adolescent stage. So vicarious trauma, it's a pretty common occupational phenomenon, and the prevalence of symptoms ranges somewhere between 15 and 35% of workers across different fields. They might experience emotional symptoms, so they might develop avoidant behaviors when they're working with certain patients or clients. Cognitive symptoms, so they might block out certain interactions, gaps in memory, somatic symptoms, rapid heartbeat. And a number of studies have demonstrated strong links to poor mental health, such as anxiety, depression, PTSD, as well as organizational outcomes, such as lower job satisfaction and turnover. So these symptoms, I think, are arguably a natural byproduct of working with trauma survivors. And so because of that, I think people tend to believe that because this is just going to be in the work environment, then we're going to have workers who are traumatized. And I want to push back on that assumption, because I think it's possible actually to reduce some of the exposure to vicarious trauma while still providing good services to individuals. And while we won't be able to fully eliminate vicarious trauma in the work environment, because we're going to need a workforce that's still working with trauma survivors, I think we can reduce it or figure out exactly how people are being exposed, figure out then what additional supports they need and the organizational structures to support that. So these symptoms take a pretty sizable toll on both workers and organizations. So these quotes here are from a qualitative community-based study I led with residential addiction treatment organizations funded by a pilot study from NIOSH. And this counselor shared, there are these cases that it's hard to walk away from, and it can invade our personal space, produce a trauma response like nightmares, flashbacks, thoughts, or even imagined images. I really don't think the administration understands how stressful it is to walk through trauma with people daily. And then this facility leader linked vicarious trauma at the staff level and how this was then impacting the organization's actual ability to deliver treatment. And they said, honestly, I 100% they feel that the biggest challenge for staff is really secondary trauma and turnover. It's probably the biggest barrier to quality care. There's an exorbitant amount of money and resources and management time being dumped into constantly rehiring and training because it's a very low pay, high stress job. So I also want to take a moment to just speak briefly about how I came to this line of work. And so, as Deborah shared, my background is as a social worker. And after I went to grad school first time round, I stuck around Philly for a while and was managing the community health worker program at the hospital at the University of Pennsylvania. And then I switched gears and was supervising domestic violence counseling and prevention programming at this large multi-service organization in the north of the city. So I'm working in these, frankly, trauma-saturated environments. I'm seeing the effect that's on the mental health of my teams, what seems to be also their physical health, and they're leaving their jobs. So this kind of like wonky parallel process that seems to be happening at the organization level. So we have clients operating in crisis, and then the organization seems to be operating in crisis and kind of mimicking that, and it's affecting the organizational decision-making. And frankly, I just felt really stuck about, I didn't know how to make these work environments healthier for for my teams. And so this is what led me to go back to school to pursue a PhD at the Harvard School of Public Health, specifically to work at the Harvard Center for Work Health and Wellbeing, which is one of NIOSH's total worker health centers of excellence. So total worker health, you'll have a center for it actually here at WashU, but for those of you who might be a little less familiar, it's an ecological perspective for identifying the variety of different factors that are affecting organizational working conditions, workers, and the outcomes within the organizations and the larger social political factors that are affecting that. And so I want to get more familiar about total worker health and how we can start to bring this more to the social service and healthcare work environments. So as a social epidemiologist, I think a lot about theory, and I'm trying to situate the stress and trauma theories within a total worker health framework for these kind of helping environments. So this conceptual model is essentially a translation of the stress response pathway for vicarious trauma, and then think about healthcare and social service organizations. And so this is kind of shows how it can get under the skin, so to speak, to affect our health and generate health disparities. So usually when you have some type of trauma, you first have the exposure to it, which kind of have direct health outcomes, like if thinking about an injury, for example. But with psychosocial exposures and stressors, oftentimes it's first appraised by the individual. They're thinking, is this negative? Is this benign? What resources do I have to cope? Which then can affect the response, the symptoms for vicarious trauma, which then over time can affect worker outcomes. And I also posit can affect patient outcomes too, thinking about the turnover that can sometimes happen or how they're able to function in the workplace. So I also want to use this to illustrate a couple of key gaps in the literature of what we know and don't know about vicarious trauma. So the first gap is that by and large, almost all of the research is cross-sectional. So as everybody in this room I'm sure knows, that means we can't really tease out that temporal relationship and identify any reverse causation. So the second gap is that by and large, when we're looking at outcomes, they focused on mental health, which is important, but also they haven't looked at physical health yet. The third gap is that we actually haven't had a way to measure the exposure in the work environment. And that's then, I think, really precluded thinking about what parts of the organizational environment can be leveraged to intervene and protect workers. And then the fifth gap here is identifying how vicarious trauma at the worker level also affects patient care and outcomes. So the first two studies that I'm going to be sharing here are going to start to address gaps 1 through 4, and then I'm going to speak a little bit to gap 5 later on in the research agenda. So on that note, I want to transition to study what I think is or we think is the first study to look at how vicarious trauma prospectively affects physical health, specifically common gastrointestinal disorders. So as I mentioned earlier, numerous studies have shown a consistent relationship between vicarious trauma symptoms and mental health. But physical health has been largely unexamined. However, there's this whole body of literature, right, of firsthand trauma and how that affects the physical health of individuals through behavioral, psychological, physiological pathways. So it seems quite plausible that vicarious trauma would also be affecting our health. 2 studies have started to look at this cross-sectionally with self-reported general health, but there's a lot that we need to do to be building on that. So to start addressing this gap, I decided to look at the relationship with disorders of gut-brain interaction, or DGBIs. And these are conditions thought to be caused by complex, dysregulated interactions of the central nervous system, autonomic nervous system, and gastrointestinal system, often triggered by stress. So we're thinking irritable bowel syndrome, GERD, functional dyspepsia. People, they don't experience these symptoms continuously, but they often have flares every 3 to 4 weeks. And some people choose to self-treat and some people seek medical care. But importantly, among individuals who have high degree access to healthcare, such as the healthcare workers that are going to be in this study, there's actually very little difference between those who choose to self-treat and those that seek medical care. So if we're thinking about starting with a physical health outcome, I think DGBIs are a particularly good place to start. First, because there's already an established relationship between DGBIs and firsthand trauma and occupational stress. It's also has quite a sizable public health burden. Between 20 and 40% of the population globally will experience one of these at some point in their life. So it has that burden, but also it's not a necessarily a rare outcome. So it's might show up in the data if we're looking for it. It also, compared to other health conditions such as hypertension that have been associated with stress and trauma, it has a relatively short etiologic period. So we don't need as long as follow-up periods. So that can also help reduce the amount of confounding. So with this in mind, my primary research question was, what is the prospective relationship between vicarious trauma symptoms and DGBIs among hospital workers? Hypothesizing that higher vicarious trauma scores would be associated with increase of DGBI over a 1-year period. And this starts to address the first and second gaps that I've identified. And then as a secondary exploratory question, I was curious to see if a supportive work environment buffers the relationship between the symptoms and DGBIs. Could that something about the work environment be leveraged to protect workers? So to answer this question, I leveraged data from the Boston Hospital Workers Health Study, which is a cohort study of nurses and patient care associates, such as medical nursing assistants, techs at 2 large hospitals at Boston, and then restricted the sample to individuals with an employee health plan. So when I came to Harvard, the PI of the study knew that I was really interested in vicarious trauma, and so they let me slide in a vicarious trauma measure to the 2018 survey wave, which I'm very grateful for. And then the survey also just contains this wealth of other important demographic and work structure measures that are important controls to answer this question, as well as measures of supervisor support, coworker support, and people-oriented culture, which is kind of like a measure of worker voice, which I use to operationalize the supportive work environment. And what's particularly neat about this data, at least I think, is that because the hospital system's self-insured, I can then link the survey data to their workers' health claims data. So we can observe an objective measure of health through ICD diagnostic codes. So using the claims data, I was able to identify DGBIs after the date that folks took the survey, and then also control for DGBIs that occurred starting in January 2017. So use multi-level logistic regression with hospital units as random effects, testing first for effect modification by the supportive work environment. But if I didn't see evidence of this, I then added them in as controls, theorizing that would confound the relationship. And I did this modeling vicarious trauma symptoms both continuously and breaking it up into categories of high, medium, and low symptoms to assess potential non-monotonic effects. But those are the results I'm going to share today in the interest of time. And then some additional sensitivity analyses, so restricting the sample to just nurses, so a more homogeneous population, and then to those that without a history of DGBIs. So a quick glimpse of who participated. Most were female, and most were white, which is as it is in the workforce as in our country. And across all the characteristics here, there was a statistically significant difference between nurses and the patient care associates. So what did we find? So after controlling for demographics, baseline DGBIs, job structure, the odds of developing a DGBI were over 2 times higher for individuals with high vicarious trauma compared to low. We didn't see evidence of effect modification. So when we added these variables in as controls, we see that the odds of developing a DGBI jumped to almost 3.5 times higher with high levels of vicarious trauma compared to low, which is statistically significant. Though I do want to note the wide confidence intervals because this is the rarest category of exposure. I also want to point out here how the supportive work environments are functioning. That usually when you add in additional controls, not always, but often, that main effect is attenuated. And instead here, it's increasing. And then the direction of these effects are not what you would necessarily find, right? That higher support is associated with more of these health conditions, though potentially those are, we have supportive work environments that allow people to actually go to the doctor. And I think that could explain a lot of that. But what I think is also important, and this illustrates just is how important it is to when we're trying to identify this relationship, really capturing these other aspects of the work environment, specifically the supportive relationship, to see that true magnitude of the association. So, and then when I restricted the sample looking at nurses and folks with no baseline DGBI, we see a very similar pattern of effect. So there seems to be some consistency in these findings. So this is the first study to prospectively look at vicarious trauma symptoms with an objective measure of physical health, and that we see that these symptoms do seem to increase the odds of developing DGBIs within a 1-year period. And this relationship might not be monotonic, that higher levels of vicarious trauma may be particularly toxic to workers compared to lower levels. Though, of course, it's important to consider a few limitations of this. One is that we didn't have a measure of psychological like firsthand trauma, which would be an important confounder. But we did calculate an e-value, the amount of confounding that would be required to fully attenuate or make it not statistically significant. And you need a lot of additional residual confounding to explain away this result. It's also important to think about this healthy worker effect, selection bias, that the individuals with higher vicarious trauma and those where DGBIs are less likely to stay in the workforce, more likely to leave. They wouldn't be in the sample. So if anything, if they were in the sample, it probably would mean that this relationship was even stronger. So, and then thinking about kind of, as I mentioned earlier, thinking about looking at other relationships between vicarious trauma and physical health, I think this illustrates just how important it is for us to be including aspects of the organizational work environment in our analysis to see that true effect. So before moving on to my next study, I want to return to this conceptual model. So the study I just shared was really focusing on these parts of the model here. And the reason it's focusing on vicarious trauma symptoms is, as I mentioned, we haven't had a way to measure the exposure to vicarious trauma. We actually have 5 different measures of vicarious trauma symptoms, so that we have our choice there, but no way to measure the exposure and what people are actually, how they're encountering vicarious trauma at work. So now we want to shift focus here further upstream in the model to discuss the development and testing of the Vicarious Occupational Trauma Exposure, or VOTE Index, which was funded by an R36 I received from the National Institute on Drug Abuse. I also want to note that this has absolutely nothing to do with voting. I'm not great at acronyms, so if anybody's better at it than me and wants to, I mean, it's kind of hot off the press, so we have a chance to change it. So let me know. So the aim of the vote is to identify where workers are exposed to vicarious trauma, how often this occurs, and how distressing this is as a marker of the severity to provide a way to measure the exposure in work environments and start to fill this gap. So because we haven't had a measure of exposure, we've been pretty much left in the dark about what folks are actually encountering that's driving these symptoms, and then where we should be intervening in the workplace. So there's a recent scoping review by Kim and colleagues out of UNC that found that there haven't been any evaluated organizational multi-level interventions to address vicarious trauma, and everything has been at the individual level, thinking about types of self-care and mindfulness, which we know leads to differential uptake among workers. It's harder to sustain over time and can also widen occupational health disparities. So it's also really hard then, without an exposure measure, to evaluate these interventions, because there's organizations that are in the practice world that are trying to protect their workers, but you can't really evaluate those, right? Because the organizations that are more likely to institute some type of practice are also the ones that probably have higher exposure for their workers, and you have this differential exposure that you need to be able to control for to see if it's effective. So as part of this goal, this measure was designed to be free and publicly available for organizations, researchers, policymakers, and we validated it with the substance use disorder workforce, or the SUD workforce, which has a demonstrated high prevalence of vicarious trauma symptoms. So the vote was developed over 3 phases following standard instrument development methods. I'm going to go over the first 2 phases pretty quickly at a high level, but happy to talk about it more in the Q&A. So I started with coding qualitative interviews and focus groups for how folks were describing being exposed to vicarious trauma, then also conducted a systematic review of the vicarious trauma literature across different helping professionals. And I used that information to develop draft versions of the VOTE Index, which then I shared with experts in trauma services, occupational health, psychometrics, and then also conducted a series of cognitive interviews with SUD workers across the country, and using this feedback iteratively to modify and test it again. And then in the final stage, we tested its psychometric properties in a national survey of sub workers. So what does it look like? So I identified 4 domains of vicarious trauma exposure. The first domain is clients sharing about trauma, which is, I think, what people most readily think about when they think about vicarious trauma. But there's other sources as well. So thinking about receiving and reviewing evidence of trauma, such as photos, drawings, videos, diagrams. Then also kind of documenting and reporting of trauma by the worker, which requires a certain level of re-envisioning within one's own mind and putting it back out there in the world. And then the last domain was staff either sharing with each other about the trauma that clients have experienced, or maybe they themselves have experienced in their personal lives, knowing the high rates of shared experience within a lot of these workforces. We spent a lot of time going back and forth on how, like, the best way to assess this. And we settled on a 2-part assessment where individuals first report how often in the last 30 days they've experienced one of these exposures, and then how distressing that is usually for them. So to test the VOTE index, I developed partnerships with 9 of SAMHSA's regional and national addiction technology transfer centers, which are these centers that work directly with workers and organizations to disseminate best practice and provide trainings and the like. And then I also developed a relationship with a primary professional organization. And so we were able to recruit a little over 1,400 individuals for our final analytics sample, which we quota sampled to approximate the workforce according to statistics from the Bureau of Labor Statistics, since we didn't really have a sampling frame that we could pull from, excuse me. I also want to note that we doubled, almost tripled our sample size and what we were planning to do, because there's just this outpouring of interest from workers across the country, which I think also speaks to how this really resonated with what they're dealing with in their work. My thought was that it should be theoretically stable over a 2-week period of time. So to assess that, I resampled a group of participants 2 weeks later to assess retest reliability. And then when we analyzed the psychometric performance, we did so in 2 ways. The first way was by looking at the straight up exposure frequency. So like summing all of that together for a total score. And then the other way was creating a weighted version, whereby each of the exposure frequencies will be multiplied by the corresponding distress score. And the reason I wanted to look at it for both ways was that the weighted version, I think, makes more theoretical sense, that not every exposure matters the same to an individual. The severity matters. But if you look at the life events in trauma literature, they've been grappling with this, and they have found that measures that just have a frequency of events compared to ones that are weighted, they actually tend to perform comparably. And so if there's a simpler tool that we could make, right, for organizations to use, maybe the weighted version is better for research, but maybe organizations could really benefit from the simpler tool. I want to know that. So when you're developing an index or an instrument, you pretty much look at everything in every single way, which is incredibly tedious. And I'm not going to put you all through that. But I did want to give you a glimpse at our convergent validity, so how well it correlated with what we think it should be correlated with. So we looked at a measure of vicarious trauma symptoms, general psychological distress, and somatic symptoms, job satisfaction as well, and intention to leave the job. I also want to assess discriminant validity, so that it shouldn't correlate with what you think it shouldn't correlate with. And it's really hard to find a measure that has nothing to do with the psychosocial stressor. But I came across the celebrities attitude scale, which is essentially like how much you like to hang with your friends and talk about Taylor Swift. So I thought that should be associated. And then to assess retest reliability with each of the items, I looked at the weighted kappas and interclass correlation coefficients, and then for total scores, looked at the ICCs. So quickly, most were women, as is true of the workforce, and about 2/3 worked in addiction treatment specific facilities like detox, but some folks worked in, for example, drug court or school-based prevention. Majority worked in direct service, but not everybody. Some were perhaps in leadership positions, and that's by design so that we could have a fuller distribution of the exposure as we're testing it. So I mentioned that I was looking at both the weighted version and the unweighted version. And so when we're looking at convergent validity, we see that it's correlating really strongly across all of these measures for both the weighted and the unweighted version. So that's great. That's what we want to see. In terms of discriminant validity, we didn't see any correlation with how much folks cared about Taylor Swift, which is also what we wanted to see. And then for retest reliability, it actually performs excellently for a psychosocial measure. So we want to get as close to possible to 1 here. And we do see that the weighted version is a little bit lower, which it's still a good score, but I think it also makes sense that it's lower because if you're thinking about your own ability to recall how often something happened in the last 30 days versus the emotional valence behind it, it's a lot harder to remember the your emotional reaction. So while I think the weighted version is perhaps theoretically truer to what we're getting at, there is more measurement error there. So we see, as you know, this is the first instrument to measure vicarious trauma exposure, and it demonstrates pretty good reliability and validity in a national sample of the SUD workforce with both the weighted and the unweighted versions. So if we're thinking about putting it into use, I think it can be really useful for occupational epidemiology and healthcare and social service settings, identifying the burden of vicarious trauma exposure across different fields and different jobs. But what I'm most jazzed about is the opportunity for intervention work. And that we'll be able to see like who could benefit most from additional supports or redesign of the work, or what are these hot spots where how people are really getting exposed, which probably is going to differ by field and job. A notable limitation is that this was validated with the SUD workforce. And like with other measures, we need to be thinking about how well it performs with other workforces. And so to that extent, I'm currently working with a colleague at the University of Minnesota to validate it with sexual assault nurse examiners. That's also an important link to using in the healthcare workforce. So, those were 2 studies that I want to share that are starting to plug in some of those gaps I've identified in the literature. But I think we need to do so much more about translating this also into practice so that we can stabilize these workforces that were essentially hemorrhaging. And so y'all gave me a platform to stand on and a mic, so I'm going to take advantage of that and share what I think we should be working on, though this is by no means exhaustive. So, all of the occupational epidemiology, the intervention work, the practice and pedagogy, it all needs to be informing each other. But to start with occupational epidemiology, I think we really need to be investing long-term in cohorts of helping professionals, also lower wage workers upon whose labor we're wholly dependent for our health in our communities. And it's not just vicarious trauma, right, that's affecting these workers. It's a component, but folks are also, they're not paid enough. So low wages, moral injury, physical injury, these larger austerity measures that are impacting these work. We need to be capturing this. And that's where I think that total worker health perspective to identify all the confluence of factors and how they're interacting to shape the job trajectories in these fields, who's leaving, who's staying, and to be able to capture that and plan for what we need to do. With better methods, with better data, we can use better methods to look at the mental and the physical health. So building on the research I shared earlier, the first study, I'm currently looking at vicarious trauma symptoms and the effect on cardiometabolic health and musculoskeletal injuries. But there's a lot of room to join me over here if anybody's interested. I think we also don't have to reinvent the wheel here, that there's a lot we can pull from the direct trauma literature and what we know about the causal mechanisms and see how it's affecting the workforce here too. I think we also need to be making a far better economic argument for organizations and businesses that are running healthcare and social service or like recovery settings to be signing on to addressing this issue and prioritizing their workers. So I'm tapping into this to a degree, looking at the cost, the healthcare costs to employers with claims data. But if you think back to that quote I shared at the very beginning from that organizational leader, there's a whole other host of costs to organizations, thinking about the turnover, the hiring, the absenteeism, the presenteeism. These matter to organizations. So if we can really marshal that economic argument, I think we can create good partners here. We also know when it comes to firsthand trauma that only a minority actually develop PTSD or other mental health conditions. And presumably the same is true here with vicarious trauma, but because we haven't had a measure of exposure, we haven't been able to see that or figure that out. There's a lot of ethical considerations when thinking about like a tolerance threshold, what workers should be able to withstand. And we need to be very cautious when we do that, but understanding what might be tolerable kind of as a goal, as like a signpost for interventions, what we should be aiming for, knowing that we can't reduce vicarious trauma completely, I think can be helpful for intervention design. So thinking about then interventions, we really have to be focusing, I think, at the organizational level and not just at the individual level. And also think about policies that might be shaping the organizational working conditions, which then kind of have the downstream effects on vicarious trauma. So I also think that, there's so many, like these organizations are all so different and they're evolving differently. And so as we're thinking about what can we do to intervene around vicarious trauma, as well as the other issues that are affecting workers that travel with this, we need to be thinking about testing interventions that are much more about a process than this cookie cutter intervention. And so to that extent, I'm currently working with the Massachusetts Bureau of Substance Addiction Services to test one of these processes that brings workers across levels to identify what matters most to them and help them to figure out what they want to do in their work environment and sustain that and then identify the next thing. So we submitted our grant to NIDA in the fall. We all know about the funding environment. We'll see what happens. We can talk more about that. But as part of that, we are embedding a cost-effectiveness analysis, which I think is also, once again, important for making this economic argument. And the Massachusetts Department of Public Health has agreed to sign on to sustain this program if we can show that it's effective. And of course, with anything that's effective, we need to be thinking about scaling this as well as adapting to other environments. So, once again, if it's effective, we need to be thinking about how we're getting that out into practice. How can we be reaching leaders and also middle managers who are actually shaping a lot of the day-to-day with their workers? I've also been reflecting a lot on my own MSW and MPH experience, and that I think we're really good at training students to think structurally about how these factors are impacting individuals and communities' abilities to thrive. And then when we think about their own ability to thrive, we're kind of told, like, figure it out. And if that conversation even happens at all. But the students that are coming through our classrooms, right, our public health students, our social work students, our healthcare students, ideally they're staying in the work and they're moving into leadership positions, right? So we need to be planting that seed now that they should be prioritizing their workers and how to do that and what the resources might be. And so that also, I think, we need to be giving them the skills to do that too, which can then, I think, will feed back into these other components. So thank you for letting me stand on my soapbox to discuss that. We're going to wrap up and just thank everybody for coming out today. And I'd love to answer your questions and have a conversation. Sorry, I'm parched, but please.
No problem. Thank you so much for that talk. I have a question about experience and age and how that interacts with vicarious trauma. And I guess in my mind, I'm thinking I could go either direction, that people adapt to the experience, and so then they report lower vicarious trauma experiences, or that it accumulates over time. And have you noticed any differences in their experience or length of time in their position?
Yeah, I mean, I think you're thinking about it. I think it cuts both ways, and it's like really hard to identify because of this like healthy worker effect and who leads the workforce. So I'm not going to give you a straight answer. I'm going to just kind of share some of the things I'm thinking of that probably aligns with what you're thinking. So usually as we age, what we've found is that we get less stressed out about things. We have a more resilient, our tolerance is higher. So as you could kind of think about that resilience there. But also in terms of the workforce, the folks that are kind of encountering this daily, they might have left. So we're not necessarily going to be seeing that, which also could make it look then it's like potentially younger workers who are most affected. Maybe that's an artifice. Maybe it's actually kind of where we are in our own like life trajectory. It's hard to tell. There's also, you could also think about the folks that are staying in the workforce after a long period of time. Is it resiliency? Or there's also people that are kind of reporting deadening. And I've had some conversations about the vote index too, because we have this distress component, right? And I shared just the quantitative analysis, but we're in the process of coding the qualitative that we are asked people both for feedback about how it performed and or for them and answering the questions, and then vicarious trauma generally in their work. And what we're hearing, not from everybody by any means, but it's come up a couple times of people just feeling like, am I a monster for not feeling distressed? I just feel really dead inside. And so I think that also that is some measurement error that I'm not sure how to get around. Some people have suggested that you could create kind of like a population, an occupational average, and not have folks report their own distress. But I think that's if we're hoping to use this across different helping professionals, I just don't think that's practical because the amount of studies we would need to do and it probably even varies according to role. It's just not practical, and I think it can discount also that lived experience too, and the reporting of that distress, that is important information.
Maybe just adding a numbing question, how
Maybe, yeah, just like, or but then I don't know, what do we do with that?
Yeah.
I think what is heartening about this is when you look at like the unweighted version, which is just the frequency, which shouldn't really be affected by the kind of numbing. It's performing also really, really well. So I think there's some measurement error, but maybe it's not as big of a problem as we think, and that as kind of more of a heuristic or like a way to be, this is not designed to be a diagnostic tool. And so if we're using this as an organizational tool, I think it still has a lot of value, though it's like, it does, so like there's some measurement error there. Yeah.
Thank you so much. Great presentation. We're working on developing a preparedness to extreme events index. So probably just use you as a way to teach myself how to do this. This was great. But I have two questions actually. I think there were slides 26 and 20. Maybe
You want me to go back to them? Or?
Yeah, maybe 26 or 27, I think. But I was wondering,
is this one?
Actually, maybe after the results. Oh, sorry. I think the last one. Just after this.
You mean this one? This is the methods?
Then it's fine.
Cool.
The
Great.
first one was the result from the, I think it's probably 30. The result from the test retest. Let's start with that.
Yeah.
So how do you get to the sample that I was interesting to see like 94? That was the sample?
Yeah, so I mean, I did a power calc. You actually don't need very many
Yeah.
people for to assess the temporal stability.
Yeah.
And so it's a lot smaller than our actual
Yeah.
sample. So what I did was in the survey, I just asked folks, would you be willing to take it again in 2 weeks?
Okay.
And then randomly sample from those folks to then just like shot them an email and be like, hey, you said you'd do this.
Yeah.
Here's another $10.
Oh, this
So.
is That's great. And I swear I'm not a p-values person. I'm a social epidemiologist, but I saw that for the celebrity attitude. Would you say that was a confidence interval that you were comfortable with in terms of the?
Yeah, so what we really didn't want to see is that it was associated.
Yeah.
So that you see it actually goes in different directions,
Yeah.
which I think is just kind of this natural variation. We just want it almost says that like it's just really
Very
not
noisy.
correlated,
Yeah.
and that's what we want. Yeah.
Okay. So you're
Yeah, good question though. Yeah.
So Beth, thank you. Really interesting, and thanks for coming and visiting us.
Yeah.
I have one comment and one question. I think.
Sure,
So,
yeah.
Comment is, I think the secondhand smoke analogy was interesting. I think it fits. I think there might be a third-hand smoke
Yeah.
analogy as well. It's in the fabric, it's in the organization.
agree.
It might rub off on you, sort of thing.
Definitely.
Don't know. Third-hand smoke is when you're in a smoking environment and it's in the fabric. It's on surf furniture, especially kids will rub it in.
I think I should just switch to that because secondhand almost insinuates maybe somebody witnessed, which I think is actually more firsthand trauma than secondhand. So I'm just going to switch that to third hand.
Right.
Yeah. I should have had you in my practice. Yeah.
We'll take the dog. The question was, in your model and other work, is anyone really looking at the home environment? I didn't see that listed. It seemed like for physical effects, the home environment could be very important. And that's being looked at.
Kind of, and just so I understand your question, are you thinking about what types of resources might be able to for kind of modifying how somebody is like appraising or is it kind of like thinking about the patient outcomes, the knock-on effects to family members who are living in the house with somebody who's experiencing vicarious trauma?
I was just thinking, probably there are multiple ways. I was thinking more of, if you're seeing physical effects, it may have as much to do with what's going on at home as it might be with what's going on at work.
Yeah.
You know, some of those effects might come from not always trauma in the home, but just other stuff like instability, or my child is struggling in school, or other
Mhm,
things, and it's
yeah.
having an effect on me.
I think that's true. I think that can lead to additional psychological distress, which can affect our health, our GI health. I would say that, so like 'cause you're kind of getting at this like additional like residual confounding. We don't have really measures in this because it's an occupational cohort. Like we didn't have a lot there. I would say what I think the biggest confounder would be is psychological or firsthand trauma. And as I mentioned, we couldn't get at that there. But I think I want to make sure I get the. Okay, we did a couple different slides. Oh, here we go. Okay, so I don't know if folks are familiar with an e-value, but it's a way to kind of get at this residual confounding and how concerned we should be about this. Because you're right that this is observational data, and there's always going to be like things that could be affecting this that we weren't able to control for. So this is a calculation that's developed by Tyra Vanderweel. And so it's essentially what is the, in this case, odds ratio that would be required with vicarious trauma and DGBIs. So both of them, how much would this first one would be to like explain away the results of what we're seeing and then to move it so it's no longer significant. And so then, and that's just like one variable. And so then if you look at our model and the associations with all these other factors that are probably very closely related, we don't get anywhere near that strength of that association. So we would actually need, it'd be highly unlikely that that would fully explain what we see. But I do think that though our lives are more complex than just the work environment. And that's kind of, I think, where that total worker health perspective can really shape that too. Yeah.
Beth, this was really interesting. Thank you so much. It's such a real problem. I didn't know that there was a science behind it, so this is exciting. Two questions. When it's a dose question, first of all, with so much of like mental health counseling, addiction counseling, crisis counseling moving out of in-person exchanges, I'm wondering if vicarious distress is diminished by physical distance.
Yeah, so that's a great research question. Do you want to do that together? So what I can say is that we did include remote workers in the validating the vote index, and we see that it's performing really well with them too. So it's not so much looking at the dose, but it is still correlating with what we would expect it to correlate with. So there's definitely still the exposure, but is it reduced? I'm not quite sure. And I mean, I could look back at this data and like reanalyze it for that. So that's,
right now,
but it's not a huge, no, I'm not gonna like have you wait while I do that. But it is really interesting. And I'm also thinking about kind of like, yeah, we have like, I don't know, I keep getting like on NPR, if you're like BetterHelp advertisement and stuff like that. And like, you know, folks are supposed to be available 24/7, like thinking about that, if that really is a person there, not sure, but what is that work structure and that demand? And like, how does that kind of thinking about that almost from like a shift work perspective, how that's interacting? So I could see like remote work almost cutting both ways because I've also heard from folks doing cognitive interviews that the things that are most distressing for them are the things that they feel like they have less control over. And so with that, there's an item in the vote index that assesses, I hear about how communities and social systems have created trauma or harmed an individual. I don't have the exact wording. And that consistently seems to be rated higher for distress. And I'm thinking that in the remote environment, you might hear a lot, but feel less connected to the individual, maybe feel like because they're out there in the world, you have less ability to help and support. I'm not quite sure, but I could see that actually then maybe increasing some of the distress too. I don't know. It's a good question.
Deborah, can I ask another
No, you
question?
cannot.
Okay.
I think we're all having dinner, so we're going to talk about that.
Yeah, well, I've got a lot of questions.
Okay.
So one of the reasons that people go into these positions is that it fulfills something for them. They have a sense of purpose about it. They get gratification out of feeling like, in the instances where they do that, they're helping people. Like, how does that factor into your thinking about what the effects might be? Like, is that a buffer to vicarious trauma, or like, how would you factor that into?
I'm trying to think about this almost from more of a causal model perspective that, is that baseline? And so do you control for that? Is that a modifying it? How time varying is that? Because does that dissipate over time as people stay in the work and it no longer feels that way? So we don't have that time, like multiple points in time. And I think it is time varying. I think you didn't ask this directly, but I think it kind of taps into it, is people often go into this work because of shared experience and that they've experienced something and they've have hopefully worked through it and then want to give back to that space. Working in the domestic violence space, that's very common. The addiction treatment space they work in, about 50% are in recovery themselves. And so most of the vicarious trauma research is cross-sectional. And I've seen it cut both ways, that there's maybe perhaps a higher level of resiliency with people with that shared experience, or that they are more vulnerable to it. And I think that has less to do with vicarious trauma and more to do with the individuals and the organizations that are saying, like, you're ready to do this work. So that's something that, people have been struggling with. I think it's interesting and important to be thinking about this from a workforce perspective, but also we don't even have enough workers to start with. And, that's where I think, given also the high rates of trauma, we need to be thinking much more from this like universal design, organizational working conditions perspective, because, workers might disclose that they have, I know this isn't quite what you were getting at,
No,
but
it's related.
That they have maybe a shared experience, but they're not required to, and nor should they be. And we need to be keeping whoever we can that wants to come to this field, we need to be keeping them here. And so that's where, I really think we need to take these universal approaches to thinking about the workspace here. Yeah.
Yeah, great. Thank you. And thank you for the presentation. I thought it was fascinating and related to that, and kind of it being back to like in the fabric. I mean, we know from all types of other occupational settings that when we reduce when we reduce injuries from other physical or biological or, radiological hazards, that comes from the top, right? It has to be a culture of safety.
Yes.
So back to that coming from the organization and from the leaders in the organization. And so I love what you're saying about teaching our social workers and our public health folks and our healthcare workers to think about that in their leadership style and how they're going to incorporate taking care of their workers. But for organizations out there now, like a lot of times people get into roles because, they move up into them, right? And might not have that training and understanding. So I wonder if there's also, if you've looked at maybe the relationship, or if there's a correlation between what the workers are feeling around support and what the leaders are perceiving as the support that they provide, and if there's any disconnect there. And then secondly, thinking about those interventions, are you working with organizational psychologists or anybody, in those fields to kind of help think about how do we set up these organizations in a way that we can best support everybody in them?
Yeah. So I would say that I've seen both. I think it's really dependent on the organization and how kind of like healthy that organization is from the leadership. So the quotes from the study I shared with addiction treatment facilities, that qualitative study, overall, we saw a lot of concordance between what leadership was saying staff needed and what frontline workers across levels said they wanted and needed. A lot of the leaders felt really like they didn't have the resources in their policies, though, that were shaping the working conditions, and they didn't have the power to change them. And so I think when we think about organizational leaders also, we like to think that they have the power to do so. Often, I think in more for-profit settings, there is more power, but in a lot of these state-funded and supported organizations that are heavily regulated by the state, they don't have So we also I didn't share that research really here, but thinking about what are the policies at the state level also and bringing that in as part of the conversation too. But I know that the organizations that participate in the study, there's a lot of selection bias because we recruited from organizations, and the ones that are really supportive of their workers and want to hear what they're saying are going to be the ones that share this opportunity with their workers. So there were some times where I heard, when I went to somebody had power, but it was part of a larger multi-service organization, that you start to hear oh, they don't get it. And so I think both are there. In terms of this intervention, we have folks that are in occupational health, implementation science, organizational sociology that are involved in this, and a lot of social workers co-designed with the leaders of the facilities and folks at the state. But we don't have folks that are specific in organizational psychology at the moment. Is your background in organizational psych?
No.
Okay, I was gonna be let's talk. But I think that's something that we could benefit from for sure. We also have a larger advisory board with this as well, and room to bring in those expertise. Yeah.
Well, that was great. And we're almost out of time because Matt took too many questions. We're used to that. So thank you so much. That was great. And thank you for presenting.
Oh, well, thank you. Thank you so much.